So next is Meckel's Diverticulum V27. A 25-year-old male is referred to you with abdominal pain, distension, constipation and vomiting for 12 hours. 4 cardinal symptoms of obstruction. On examination, his abdomen is distended and tympanic, diffusely tender but not peritonitic. There are no visible scars. He is apyraxial and has normal blood pressure and oxygen saturation but is tachycardic. What is your immediate management and what investigation do you want to arrange? I am concerned about fluid depletion due to intestinal obstruction from that history. I will start high flow oxygen, place a large bore IV cannula, and start IV fluids and monitor urine output. I would send for a full blood count and urine electrolytes and looking for signs of sepsis, leukocytosis, receive dehydration, and renal insult. So group and save. I would order an abdominal CT scan if immediately available to confirm suspected interstitial obstruction. Rule out perforation, identify any cause, casual pathology. If immediate abdominal CT scan was not available, I would order an erect chest X-ray and abdominal X-ray. A CT scan was not available. Chest X-ray shows no signs of perforation, but abdominal X-ray shows multiple dilated small bowel loops with visible air fluid levels. What is your management? So there is evidence of acute intestinal obstruction in a virgin abdomen. So I would arrange for an emergency laparotomy. There is evidence of acute intestinal obstruction in a virgin abdomen, so I would arrange for an emergency laparotomy. What are the most likely causes of small bowel obstruction in this patient? So congenital band due to can rise from the Meckel's diverticulum, cecal volvulus, inguinal or femoral hernia, cecal tumor, and Crohn's disease. At laparotomy, you find a congenital band rising from the tip of the Meckel diverticulum obstructing a loop of ileum. Describe your surgical approach. So I will release the band adhesion. Usually they are avascular, so I will release the scissors. I would assess the obstructed segment for the viability, allowing up to 10 minutes for perfusion to be restored unless the segment is overly necrotic. If perfusion is restored, I would inspect carefully for perforation. If it's necrotic, I would perform a segmental bowel resection. I would also resect the Meckel diverticulum since it has caused obstruction. Depending on the base of the Meckel's, so there are two opinions here. If they say it's narrow base, you can do diverticulectomy. If it's wide base, you can do resection of the segment of the bowel and do end-to-end anastomosis. The arguments for diverticulectomy is that ectopic gastric mucosa can left behind, which can cause ulcers and at the junction with the small bowel mucosa. So what is the embryology of Meckel's diverticulum? So during the embryological fetal life, the vitelline duct connects the embryo with the yolk sac until embryo placenta was established. So due to its region, Meckel's diverticulum may contain gastric or pancreatic mucosa. What is the rule of 2? It is prevalent in 2% of the population. 2:1 for male and female. 2 inches long, 2 feet from ileocecal junction, 2 gastric mucosa, and half under the 2 years of age. What other ways can Meckel's present? So Meckel can present usually asymptomatic in nature, 4 to 16 lifetime incidence of complication. The most common presentations are hemorrhage due to ulceration caused by ectopic mucosa or obstruction, inflammation, Meckel diverticulitis, and perforation. Meckel diverticulitis is clinically indistinguishable from the appendicitis. How should incidentally found asymptomatic Meckel's manage? Again, asymptomatic Meckel's found incidentally and imaging require no further intervention. For asymptomatic Meckel's found incidentally during unrelated surgery, there is little evidence to guide the management. So factors favoring resection are young age less than 50, narrow base, long diverticulum, or evidence of ectopic mucosa or inflammation. Thank you.